Good morning, everybody, and welcome back to your Lunch Break Live. My name is Savannah Harinque if you are new here, and if you're not, thank you for coming back. Today is Monday, February the 28th, and today is also National Rare Disease Day. In order to talk about that, explain a little bit about what exactly a rare disease is and talk about why this is an important day. I'm joined by UAB and Children's of Alabama medical geneticist, Dr. Anna Hurst. Now, Dr. Hurst is again going to explain a little bit about what exactly a rare disease is, how many people are living with it, and exactly what that means and how it differs from maybe some things we see on the TV shows. So, Dr. Hurst, thank you for taking your time today to explain a little bit, to talk to us. But I have to say, medical geneticist is something that I think most people read and they don't really know what they do or don't know exactly what it means, but they say, whew, that sounds pretty complicated.
Well, thanks so much for having me. It's really an exciting opportunity to be here and to talk more about Rare Disease Day. Yes, being a medical geneticist is an excellent career path. We are thought of sometimes as rare disease doctors. We see individuals who have anything different about how they learn, grow, develop, and try to see if there's an underlying genetic cause for that, because that can give us a better treatment plan for the individual when we can kind of customize their medical plan to their specific genetic difference. Like you mentioned, Rare Disease Day is today, and individually, rare diseases are rare. There's over 7,000 types, though. So collectively, they're fairly common. People estimate anywhere from 5 to 10% of the population has a rare disease. So the math of that equates to like 500,000 people in Alabama who are living with a rare disease. And today is kind of a day where all of those different rare disease groups can come together and have a louder voice collectively.
Well, like you said, that's actually a pretty big number. When people think rare disease, they
Mhm.
obviously think few in terms of rare. But I think you made a really good point, and that means that few people maybe have that one specific disease, but there are thousands of those specific diseases that only target a few people. So that's a really good point. I'm glad you made. So let's talk about this day. You said people can get together to talk about it, share resources, and to bring awareness. Why is that so important for people who live with a rare disease to be able to talk about it and say, look, listen to me, listen to this disease I have and the disease that people I know have?
Yeah, I think that really brings up the power of community. Sometimes having a rare disease can feel really isolating. And so it's so helpful for patients and their families to be able to come together and learn from each other. I mean, as a doctor, I know what I learned in medical school, but I don't know all of the specific challenges and the unique things that accompany having a rare disease. So sometimes parents and families and patients themselves can be their best advocates and can teach each other things that we as doctors aren't able to know or understand. And sometimes those new discoveries and new things that we're learning in rare disease come from the voices of patients who speak up and say, hey, this is a concern that I'm having. Is this something that research could address? And that inspires us as doctors and researchers to take on some of those issues that are most important to the community.
I have to pause to address this comment that just came in because I can
Mhm.
relate with this. Somebody says, Christy says, question: has anybody found out how somebody gets sarcoidosis? And Christy, it's so funny you say that because we know that is a rare condition here and that falls in what we're talking about. But somebody in my family actually was diagnosed with sarcoidosis, and we had this experience that Christy, I'm wondering if you had as well. That it really felt like, look, we need to call House. Where's House here? We need some help. Nobody can figure this out. So let's talk a little bit about that experience, Dr. Hurst. When somebody
Yeah.
has these symptoms and nobody can figure out what is going on, it can leave somebody feeling very isolated, helpless, and just saying, "Look, I just want somebody to figure out what's wrong with me."
Yeah, it's a great point. And so many people too end up on what we call a diagnostic odyssey, where they go to multiple doctors, different subspecialists, trying to get any information they can. And so sometimes we're, as doctors, kind of limited to our own area of practice. One thing I like being a geneticist is that we can kind of think about all organ systems, all different parts of the body that might be affected, since your DNA is everywhere and it affects so many different things. Specifically related to sarcoidosis, there are factors that are sometimes thought of as hereditary, but not necessarily one specific DNA change. So, sarcoidosis is probably one of these groups of autoimmune or rheumatological conditions that aren't single gene genetic, but are probably lots of different genetic factors all together. When we talk about rare diseases, about 70% are genetic with like a clear, genetic DNA answer that we can send a test for and say, hey, this is a change in your DNA that caused this. But the other 30% would be like sarcoidosis, where we don't have one single test that we can send. And so sometimes it's a combination of physical exam findings, a combination of lab information, also personal and family history, that doctors kind of pull all that together to make a clinical diagnosis for someone.
You've mentioned that, especially about sarcoidosis not being one specific test you can send off of, but that kind of brings another question with this being a medical geneticist. If somebody is going through this and they're seeing maybe different doctors, they can see people that are their primary care, and then they go into specialists, and they go into people doing all kinds of blood works and labs. And I
Mhm.
know that that gets exhausting, but how many times does somebody say, you know what, why don't we get some genomic sequencing done? Why don't we turn to that route? Is that something that
Mhm.
everybody goes through when they are looking for a diagnosis? Or is that something that is just kind of a new type of technology?
Yeah, so that is one of the most growing areas of genetics. And it's an area that really gets me excited because with high level genome sequencing, we can look at lots of DNA simultaneously. And instead of in the past having to pick one or two genetic factors to look at, we can look at all of a person's DNA at the exact same moment, and it saves time, it saves money in the long run. And even though it is kind of a new test, we have a lot of access to that. Within Alabama, there's some really great resources. At UAB, we have the Undiagnosed Disease Program. A lot of individuals through this program have genome sequencing. Some of that's funded by the state of Alabama through a program called the Alabama Genomic Health Initiative, which is a state-funded opportunity for people to have genome sequencing. If you get a referral from your physician who thinks that you might be a candidate, we review those and can provide genome sequencing. There are also opportunities through Children's of Alabama for pediatric patients. The hospital funds a study called the Children's of Alabama Genome Sequencing Study. And then there's also opportunities at Hudson Alpha Institute for Biotechnology in Huntsville for both research and clinical genome sequencing. So we are fortunate to be in a place where different hospitals and state organizations have felt like genome sequencing is a really valuable, important resource for the local community.
So if somebody is seeking genomic sequencing because they believe they have a rare disease, maybe they haven't been diagnosed yet, is this something that they have to have a referral to come see somebody like you or a geneticist to get done? Or can they just call an office and say, look, I'm going to take this into my own hands. This is what I'm going to do. We've seen so many people now kind of becoming their own healthcare advocate because there
Mhm.
are so many different avenues of medicine. So do you have to have a referral, or could I just say, you know what, I'm going to do this?
For our UAB genetics clinic, we do take self referrals. It always does help, though, to have previous records. And also, if you have a primary care physician, that's helpful too, because if we are able to have a recommendation or a diagnosis, we want to be able to communicate that back to your primary team. So the initial conversation can start with self referral, but definitely the more information that we have to put the pieces together, the better.
I'm just looking through the comments, and I have several questions I wanted to get to you. But first, I think it's so cool that people are talking about different diseases, either that they have had or they have heard of. So we've got some people talking about type 1 HAE, sarcoidosis, Ribbon's disease, PKU, and myotonic dystrophy. So all types of different rare diseases. So it seems like some people maybe feel more comfortable talking about theirs when they know that this is already a topic of conversation or that they're not alone.
Yes, and I think what you bring up is that power of community, because a lot of times the struggles that someone faces within a rare disease are similar to other diseases. Even if it's not the exact same thing, people have been through the same process of, struggling with insurance coverage of treatments or advocating for a child in the school system, just trying to find the right doctors and subspecialists. Some of those are common challenges that everybody faces, no matter what the disease type is. I think one of the great things that somebody brought up in the comments, you said, is PKU. So phenylketonuria is a common inborn error of metabolism. So someone is missing an enzyme that helps them break down certain proteins in foods. And that's actually something that's on the state newborn screen. So all babies in Alabama and really every state are screened for a group of conditions at birth that are rare that we have treatments for, because we don't want to miss the opportunity to treat individuals early. So the newborn screening program program is a way to help identify people who are at risk for having conditions like PKU and many others. And actually, in Alabama, we've increased the number of screens. And just earlier this month, spinal muscular atrophy is a new condition that was added to the state newborn screen in Alabama because there are new treatments available. And we have a few other diseases that are being added by the end of the year. So even within newborn screening, we're always growing and always evolving the number of things we can detect early.
We talked earlier about the journey of somebody feeling sick and feeling symptoms and trying to decide what it is, what kind of condition that they have, trying to get diagnosed and then form a treatment plan. But that sounds really streamlined, but often it's not. From that time of symptoms to getting diagnosed can be, I know, a whirlwind, and people can feel, as we mentioned earlier, isolated. They can feel depressed. Also, though, they can just feel confused, right? Not knowing where to go. We talked about all these different doctors and subspecialties. So I want to ask you, we see on TV, on these medical dramas, we can watch House, we can watch Grey's Anatomy, and somebody has a very rare condition and they get it figured out within 30 minutes to an hour, right? But that's not reality. So tell us kind of the reality of experiencing symptoms to getting diagnosed and to maybe getting genomic testing.
Yeah. So everybody's journey is certainly unique, but there are studies that show that on average it can take 7 years for somebody from initial presentation to have a diagnosis. And then the real challenge begins of once we have a diagnosis, how do we best manage this? How do we treat the person's symptoms and features? The journey can look different for different people depending on kind of where they start, what subspecialists they're seeing, what their symptoms are, what lab studies are done. And especially if we think there might be a genetic cause, that's why I'm a real big advocate for earlier genetic testing, because I think that can be helpful. Even if we don't find a diagnosis, if it's negative, we've at least ruled out lots of different genetic conditions as well. And sometimes that can help doctors focus on some of the maybe non-genetic conditions, things that are more, autoimmune or allergic or environmental.
I know that we have some people here again talking about getting in touch with you. I'll make sure to share all of your contact information here when we get finished. But we talked about this journey, and you talk about being an advocate for early genetic testing. When you say early, what does that mean? How soon should somebody seek genetic testing after they cannot get maybe a quick diagnosis? Should they continue down seeing more specialists and subspecialists, or should they just go ahead and make that call?
Yeah, so have the doctors reach out to a geneticist. We have a busy clinical practice. The patients that we see, like I said, are those with differences in growth, development, and health conditions that have a high genetic yield. Some of the things that we have clinical testing for, there's a test called exome sequencing that's similar to genome sequencing. Exome sequencing is covered by more and more insurance companies, specifically for people who have birth differences, things like congenital birth defects, heart defects, cleft lip and palate, anything that's structurally different with how the body is formed. Also, people with intellectual disabilities, like a low IQ, cognitive difficulties, those types of diagnoses. For those cases, insurance is covering more and more genetic testing early.
Do you feel like you have to be an advocate for this and you have to really get the word out? Because we have so many physicians that maybe have been in the medical field for so long, and this was maybe not a thing. And now that it's becoming a thing, we know that often you get set in your ways and you're a little skeptical sometimes of newer treatment and newer tests. So do you feel like you have to push a lot of other people to get involved in this, or have you seen a open medical community to genetic testing?
Yeah, I think people are really open to genetic testing. The real issue that we try to push forward is that genetic testing is more accessible now than ever before. People think about research, but also saying there's clinical medical grade testing that is available. Years ago, tests might have cost thousands of dollars. Now it might even be, $100 out of pocket for a patient. So the cost has come down dramatically. And I even meet patients in clinic on a regular basis who say, I've had a diagnosis for 10 years, but we'd like genetic confirmation. But 10 years ago, it was going to cost $5,000. And now we can do it for $100. And so we're able to have access to testing that helps individuals confirm a diagnosis, to know what the chances are for other people in the family. And that type of genetic information is really powerful for not just the patient, but kind of the entire relatives and all the people that are connected to them genetically.
Let's talk about being connected genetically.
Mhm,
What if I'm a person who is trying to get pregnant or wants to get pregnant, but
mhm.
I also am just curious if there is anything maybe that I could pass along to my baby? Maybe I don't know of, or I don't feel like I have a rare disease or any type of disease. Is this something that can be done preventatively or just for information in case that you are wanting to have a child and just see if you pass anything down?
Yeah, so that situation is something we call carrier screening. For the general population, carrier screening is becoming much broader. It used to be in the past, people might just screen for things that are more common in a certain ancestry group, like sickle cell and people who have African ancestry, or um, things like cystic fibrosis and people with European ancestry. But now we realize like these conditions are prevalent no matter what someone's genetic ancestry is. And so they should be available to all people. Recently, the American College of Obstetrics and Gynecology released a statement along with the American College of Medical Genetics that says that there should be kind of ancestry wide genetic screening, and then they have different tiers of groups of conditions that can be considered based on their prevalence in the population. And so individuals now are often having panels where they can screen for maybe 200 different conditions to see if they're a carrier for those. And then the step would be if someone is a carrier, then you test their partner and see if they're a shared carrier couple, because in those cases, there might be a higher chance for a pregnancy to have a condition. And sometimes people just want that knowledge. They want to be informed, they want to know what the chances are. If a child could potentially have a condition, they want to, maybe be at a medical center that's best equipped to handle and manage that. So there's definitely lots more options now than even in the past. And then if there's anything specific in your personal history, you can always meet with a genetic counselor. And genetic counselors are a really big part of the medical genetics practice. They're individuals who are master's trained. They can sit with someone and draw a pedigree or a family tree and see what are the conditions that run in the family, what might an individual be at risk for, and then help arrange specific testing for a certain condition.
So we talk about getting diagnosed, and we also talk about the case where you want to see if you're going to pass along or carry, if you're a carrier for any type of these diseases. What else can this genetic sequencing do, and who else can seek this type of test?
So, yeah, we see people, like you said, in the prenatal setting, pediatric and adult patients. Another big area of genetics is cancer genetics. We know cancer is a common condition for many people, but individually, different types of cancers are somewhat rare. There are some types of cancers that do have a strong genetic component to them. Now, most cancer is sporadic or kind of like an isolated event that happens in an individual. But when we start to see family histories where multiple generations of people are affected with the same types of cancer, or individuals who have two or more primary cancers themselves, especially within certain specific types of cancers like breast and ovarian cancer or certain types of colon cancer, there are genetic tests that could be recommended to help an individual better understand what might have contributed to their cancer, what are some of the best treatments, and what their family members might be at risk for having as well.
When I listen to you talking about what can be learned from these tests, it sounds wild. It sounds out of the just kind of medical knowledge that we feel like we have. It seems like this is a whole other world. It seems like we've stepped into a totally different world, new technology that is just broadening our horizons more than ever.
Huh. Yeah, it really has, and the rate of acceleration of knowledge, I think, is really beneficial for families now, but then also in the future as well. We know that the information that we learn from genetic testing is only going to continue to grow, and I think my hope is that that'll improve outcomes, and then that also will improve research and help us learn more that continue to develop new customized therapies and treatments.
Now, if somebody wants to come see you or if they're interested in getting this type of testing done, what's the best way to do that?
Yeah, so at UAB, we have a Department of Genetics. And so we are kind of a clinical office that your doctor can make a referral to. And so that's at UAB Genetics. And I think that information is all online. For individuals who are concerned about a rare disease, I think the General Genetics Clinic is a good first stop. And then if the condition seems, ultra rare, we have connections to the UAB Undiagnosed Disease Program. And even nationally, there's an NIH network of undiagnosed diseases. So the Undiagnosed Disease Network, UDN, is a larger scale program as well for people who might have a rare disease.
And we will make sure to get all of that information and leave it here in the comments, those phone numbers and things like that for people to access as well. Dr. Hurst, this is fascinating, and is again just something to remind us that sometimes these problems that we see are just the tip of the iceberg with the ones that we don't see and the ones that we don't hear about as often. So,
Yeah.
Dr. Hurst, thank you. Go ahead.
Oh, thanks. I was going to say too, we have a rare disease symposium coming up on Friday. If anybody in the comments is interested, we can share some information about that. It's this Friday afternoon, March 4th. It's our 9th annual rare disease symposium. And the focus is on telemedicine because that's been huge for the rare disease community, and also treatments and therapeutic advances as well. And it's open to the public this Friday afternoon.
And is that an in-person event or is that a virtual event?
It's virtual by Zoom, so we can share the links, and it's free registration.
Awesome. Yes, we will make sure that we share that as well. Dr. Hurst, thank you so much for the information. And I think we all have a lot more to research and to get involved with now. So again, thank you so much. Everybody watching, thank you. We will leave all of that information here in the comments, and we'll see you